Karanth, and the talk is how do I interpret esophageal pressure.
No response, all of you are sleeping. All right. All right. Good afternoon. So, coming to the last few talks, I think I'll be talking on how do you interpret esophageal pressure in terms of using it as a monitoring tool in the ICU for patients who do have various forms of respiratory distress on mechanical ventilation, spontaneously breathing, etc. Now, this will be a sum total or some sort of a summary of different physiological things that we have been discussing right through the afternoon, and possibly some of it also looking at going beyond the lab, its clinical application, etc. Esophageal pressure monitoring is a minimally invasive method for monitoring respiratory mechanics. Now, we talk a lot about respiratory mechanics in terms of looking at a very surrogate indices such as PEEP, plateau pressure, etc., etc. But you should understand, and as we all know, and probably have already been hearing from the morning, that ARDS or many of these lung pathologies are heterogeneous diseases. It is not as we see in a textbook where all the nice bilateral symmetrical shadows come in the X-ray, ultrasound, etc., etc. It is not like that. That we are quite aware of that. So the whole idea of using this is to see if we can be a little more specific in terms of titrating different modalities of respiratory mechanics, different modalities of treatment or ventilatory support strategies that we have. It's useful to understand pathophysiology of the respiratory failure, and if we are using esophageal pressure monitoring, type of therapy that we need to institute, or can we personalize or individualize the therapy for a given patient, actually effect of therapies on the respiratory mechanics, and monitor clinical course. So these are some of the 3 or 4 things that we try to assess or try to see with the use of esophageal pressure monitoring. It's largely remained a research tool. I think in the last 5 years that we have known about it, it's not come out so well into the commercial line, back into the clinical arena as yet. Maybe some more work needs to be done. Whether it will translate into something more useful is something we still need to wait and see, and probably needs some more clinical proof. So what is this whole principle and procedure of having a esophageal pressure monitoring? It's nothing but a simple pressure monitoring system which is actually inserted through the oroesophageal route or an nasoesophageal route or nasogastric route down into the gastric stomach, into the gastric area or into the stomach, and it is actually pulled back to the level of the lower half of the esophagus. Some authors say lower 2/3 of the esophagus, but it has to be in the lower half of the esophagus. The reason it is kept in the lower half is so that the effects of the mediastinum, heart, and the other structures which are around the middle of the esophagus or a little above that do not come to sort of alter the results or alter the pressure monitoring that we are actually doing. So therefore, it is least affected when you are actually in the lower half of the esophagus, and that is the reason it has to be positioned adequately. And the procedure described is that you actually 2 or 3 methods are described, and the basic principle is that you put it through the mouth or through the nose into the esophagus, down into the gastroesophageal junction about 55 centimeters or 60 centimeters, and pull back from there gradually to position it adequately at the right level. How do we know that it is at the right level? One is by actually looking at monitoring of the pressure waves which are there from the gastric, which converts into the esophageal pressure waves. And once you start getting the cardiac oscillations, it means you are out too far. So you need to push it back into the level where you are only getting predominantly the esophageal waves, and that is one of the things that we actually detect to find out whether the positioning of the tube is optimal or not. The second important thing is that when you actually inflate the esophageal balloon with air, you actually see at what level you are actually getting the maximum oscillations of the pressure in tune with the mechanical ventilation. So if at a given particular point you find that the pressure oscillations are the best, that means that is the exact level which you need to keep the esophageal monitor, plus of course esophageal pressure monitoring system, plus of course the fact that that is probably the optimal volume as well. Now, there are 2 or 3 brands, and each of them have their own estimate of volume, how much you are supposed to give, which ranges between 0 to 30 ml. And the most optimal is, as I said, is to see where exactly you get the most variation in the pressure at the most optimal level. So it's a bit of a trial and error and possibly a bit of manipulation that you need to do to actually get the exact pressure monitoring, exact measurement of the pressure or the area of location where you are going to measure the pressure. That is the second aspect. The third aspect is actually when you give some sort of a thoracic pressure or increase the thoracic pressure by a maneuver such as expiratory occlusion, and you find that the airway pressure goes up by 5, esophageal pressure also climbs by the same amount, it could mean that the airway pressure is actually reflecting, or the esophageal pressure is exactly reflecting what the airway pressure is showing. So you got the three things, right? One is the oscillation, the second is the pressure variation with respect to the respiratory fluctuation that you see, and the fact that when you actually give what is called as an expiratory occlusion pressure, you find that the elevation in the pressure, airway pressure, is equal or almost equal to the level that the esophageal pressure monitor will actually raise the pressure. So these three things would confirm that the positioning of the esophageal pressure monitoring device is optimal, and from then on you can actually use that for actually proper monitoring of the various pressure changes that happen in the intrathoracic space. Now, what is the concept of why do we use esophageal pressure? Why? What are we actually trying to measure? The simple thing is we are actually trying to measure the intrapleural pressure, because it is difficult to measure the intrapleural pressure without an invasive device. The esophageal pressure gives a good reflection or has good equilibrium with the intrapleural pressure, and therefore the whole idea of putting an esophageal pressure monitoring is to see that what you are actually trying to get an estimate of the intrapleural pressure. Now, before I go any further, I just want you to look at that different kinds of pressures that we talk about. So the important things that you need to remember is the intrapleural pressure. There is peak airway pressure within the alveolus. The difference between that is what is called as a transpulmonary pressure, and it is a transpulmonary pressure which is shown to have the best indicator of morbidity, mortality, and everything else that we talk about when we talk about lung injuries that happen with ARDS. So when we talk about plateau pressure and all the other things, it is a indirect reflection of the transpulmonary pressure. So ultimately what we want to measure is transpulmonary pressure, and this is probably one of the nearest we can get to actually measure the transpulmonary pressure by actually measuring the difference between the peak airway pressure within the alveolus and the esophageal pressure, which in turn is an indirect reflection of the intrapleural pressure. So the transpulmonary pressure is the PAW minus the pleural pressure, which is nothing but the esophageal pressure. Now, there are certain other forces also which do act on when we talk about the pressure within the thoracic cavity, and when we talk about compliance of the lung, it's a very vague term that we use. We are actually more worried about compliance of the respiratory system. So the compliance of the respiratory system includes compliance of the chest wall, various components of the chest wall, including if there is edema, soft tissue swelling, this, that, etc. Compliance of the musculoskeletal system, compliance of the respiratory of the lung itself. So that is one aspect of what we use for what is needed to do to consider what is called as work of breathing. So the work of breathing, which is either by the muscle or by the ventilator, is the compliance part of it, which is nothing but the inverse of elastance. So more compliant lung, the elastance will be inverse of that. And the next important component is the resistive component, or the amount of work needed to drive the air through the various airways. So these are the two things that we actually talk about when you are talking about work of breathing, or the amount of work that is needed is contributed by two things. One is what is called as the resistive component, and the second one is what is called as the compliance or the elastic component, which is the sum total of the elastic component of the lung water, pleural space, all put together. Okay, clear? Are we still sleeping, or are we a little more awake now? Right. So though I have put a whole lot of pressure monitors there, these are, at least you remember what is transpulmonary pressure for this talk, what is intrapleural pressure, and how we are actually measuring intrapleural pressure by actually measuring the esophageal pressure, and of course the peak airway pressure, which is the pressure within the alveolus. Right. So how do we, so as I already told you, validation of this positioning of the tube or positioning of the esophageal pressure system is by what is called as the Baedour test, which is nothing but you do the expiratory occlusion and you find that the deviation which happens in the extent which happens in the airway pressure will be mimicked by the esophageal pressure. So if you get this kind of a graph when you have the end expiratory hold, then you know that you are probably optimally placed in terms of the esophageal pressure monitoring. Now, if you have a patient who is paralyzed, then the recommendation is to actually give a gentle pressure on the lower half of the sternum, just like you give a CPR, not so firmly of course, a gentle pressure you give on the lower half of the sternum and see what is the extent of deviation that happens with the pulmonary, with the peak airway pressure or the intrapulmonary pressures, and that should reflect in the esophageal pressure. So, if both of them correlate, then it shows that the placement is probably optimal. So, going on to the clinical applications that we know about, esophageal pressure gives a measure of the, as I told you, a transpulmonary pressure across the alveolus. So, the transpulmonary pressure across the alveolus. Now, more than the net value of the transpulmonary pressure, it is very important to see what is the delta transpulmonary pressure, what is the change in the delta, and that is what we are actually going to try to measure, because that will give us an idea of the dynamic compliance changes that does happen when we talk about the constantly moving lung, which is sort of in a constant state of inspiration and expiration. Now, there are a number of factors, as I said, which do play in terms of, as I said, when the gas is flowing, there is a certain compliance. When the gas is static, there is a certain compliance. But on a whole lot of assumptions that we make and a whole lot of eliminations that we make, the final formula that we come to is that the delta PL or the delta transpulmonary pressure will be equal to the delta change in the airway pressure into elastance. So, essentially we are actually taking into component the elasticity plus the peak airway pressure, which is the driving pressure which comes into the alveolus to actually expand the lung. So, normally we say for a normal lung, this so called delta PL or delta transpulmonary pressure is around 15 to 20. Not good documentation, is just based on large observational data, animal studies, labs, physiology, etc. But in an abnormal lung, it is assumed that 10 is probably the safe limit, because in this heterogeneous lung, 10 could be high enough, and in certain areas it may actually be 20. The transalveolar gradient may be as high as 20, because there could be other contributing factors which we actually can't measure. So, to be safe for an abnormal lung or for a diseased lung, we would say 10 centimeter would be the transpulmonary gradient for the as a safe limit when we are actually measuring the transpulmonary gradient. So, when we talk about the so called transpulmonary pressure, I said that that's the most important sensitive indicator to decide what is the damage that the lung will suffer, to decide what is mortality, morbidity, etc., etc. Now, this also can change based on how the patient is being ventilated. Is the patient completely paralyzed? Is the patient actually taking efforts? And this is what Dr. Ram sir was also referring to about 2 talks before, that if a patient is on pressure support and is drawing up 650 ml of tidal volume, you will actually end up finding that one, there is already a volutrauma happening, and what we need to see is what is the transpulmonary gradient. So, if he is actually making an effort and bringing down the the pleural pressure, which is the pressure outside the lung, down to -20, then you say that the transpulmonary gradient has actually gone quite high. So, in that scenario, in the early phases of ARDS, it may be very essential that you actually put the patient to sleep, paralyze the patient as well, and that is probably one of the reasons why the trial where they found that neuromuscular blockade in the first 48 hours probably helped in actually improving mortality. So, essentially a patient who is having spontaneous breathing, measuring the transpulmonary gradient will actually incorporate this factor as well as how much of attempt or negative pressure is actually happening in the pleural space, which is actually measured by the esophageal pressure monitoring, and therefore that will give you an idea of the gradient, and that is why the concept of transpulmonary gradient is very important, and that is how the clinical application of esophageal gradient actually or the esophageal pressure monitoring system actually comes into play. In patients with NIV who are on an NIV mask, it's also important to measure the transpulmonary gradient, and you might say, most of our NIV machines, at least the older generation one, there was not even a measure of tidal volume, and even if you get a tidal volume on that, I don't think it will be the most accurate, because there's a lot of leak, it will measure a whole lot of gas which is being leaked out as well. So here the concept of transpulmonary pressure is actually by measuring delta P within the mask, or the change in the positive pressure within the mask minus the esophageal delta pressure, and that delta will actually give you the transpulmonary pressure. Maybe not very accurate, because again taking into account leaks and other things may not be the most accurate, but it is still something which is worthwhile to note. So as I already told you, the delta transpulmonary gradient, or the change in the transpulmonary pressure with the change in volume, is the most sensitive indicator to indicate to show you outcomes and mortality, and there is some data to support this, that this is probably the better indicator than everything else that we have done all this while. Now if you actually look at this, going back to the same figure that we saw that time, you find that the extent of change in the pressure with the tidal volume of the esophageal pressure is sort of correlates with the tidal ventilation. If you take all this into account and calculate what is the gradient, that will actually give you the transpulmonary pressure. So this is a decent ventilation that is happening. Now if this fluctuation goes quite a bit, and you find that the gradient goes beyond 10 for a lung which is diseased, then you need to be careful and put into measures other measures to actually prevent this transpulmonary gradient from actually increasing beyond 10, the delta PL from going beyond 10 centimeters. The second clinical application of relevance is actually what is called as transmural pulmonary vascular changes. Now when we talk about pulmonary vasculature and the gradient across the pulmonary vascular wall, we are actually talking about PTM, or the transpulmonary vessel gradient from within the vessel to intrapleural. So normally when we talk about a vessel gradient across, it is actually the atmospheric pressure that we take, but we cannot take that in the lung because it is actually the intrathoracic or the intrapleural space which is there. So therefore the concept of changes that we see in the heart-lung interaction, which was already described in the last couple of talks, is actually very important, which will actually help in when we talk about esophageal pressure measurement. So if you find that somebody is actually having wide swings in the systolic pressure variation or pulse pressure variation, as you can see here, it could be either a contribution coming from just the patient being ventilated plus minus the effort that the patient is also putting to breathe. So when you trigger quite a bit, or when there is wide swings in the pressure because of the effort made by the patient to breathe, you cannot say that that is actually suggestive of volume depletion. So hence it is very essential to understand the interaction between the pulmonary vasculature, the heart-lung interaction, and the effect that the patient's effort in triggering is actually happening. So in such a scenario, to actually say that the intravascular volume fluctuations happen, you actually have to end up paralyzing the patient, and therefore this is one of the suggested clinical indications, but there's still more data required to say that this is something which we can use. The next important thing is assessment of the muscular activity. Now most patients who are paralyzed, yes, we know that the muscle activity is actually not there, but in those patients who are ventilated and triggering the ventilator, work of breathing calculation can also be done with the help of the esophageal pressure monitoring by what is called as the esophageal pressure time product. So if you have this graphic, it's actually easy to calculate the esophageal pressure time product and actually deduce the work of breathing, and therefore get an estimate of what is the amount of work the patient's respiratory muscle is actually doing. See, many a time we assume that the patient is probably very comfortable, but actually when you measure the esophageal pressure gradient, you actually find that there's a lot of work the muscles are actually doing. In such a scenario, if say the patient is in severe shock and you find that if the work done by the breathing muscles is quite significant, then you actually have to put steps into place to prevent that, because the whole purpose of putting the patient on the ventilator is lost. And in fact, one of the methods that we use to optimize cardiac output is to paralyze these patients, because about 30 to 40% of the cardiac output gets shunted to the respiratory muscles when the effort to breathe is very, very hard. So therefore, assessment of the amount of work done by the respiratory muscle is one of the clinical indications that can be used. The next indication is, of course, patient ventilator asynchrony. There are about 4 or 5 types. Delayed cycling, which I'm not sure whether you can see the graph. delayed cycling which can be picked up, double triggering, reverse triggering, premature cycling, and also ineffective effort. Now, if you look at the ineffective effort, sometimes it may be very hard to pick up the ineffective effort part of it, because in a normal pressure support or in a normal ventilator, you might, this effort that the patient is making to trigger may not be picked up unless you actually have an indication to show that. And if the effort is very, very weak, it will be only picked up by the esophageal pressure monitoring system. So this sensitive sort of system which will say that there is actually an effort that the patient is actually making which is pretty weak, and therefore it will actually to optimize and find out what is the reason for the ventilator patient asynchrony is another indication where we can actually use this. Weaning is yet another indication where esophageal pressure monitoring system can be used. One is, as I said, the work of breathing assessment can be done with the help of this system. So when you put these patients on spontaneous mode, what is the esophageal time gradient, work product gradient will give you an idea of the amount of work being done. And with time, over the next few cycles of respiration, if the work of breathing continues to increase, then it is probably an indication that the patient is not in a position to be weaned. It also gives us an indication of which component of work is actually causing the patient's delay in weaning, whether it is the elastic component, resistive component, so on and so forth, in some of the patients in which weaning is in whom weaning is a problem. Now, if you find that the esophageal pressure monitoring is not very accurate, addition of what is called as the esophageal, the diaphragmatic electrical activity can also be added on to the same device, and that will also correlate very well with the esophageal pressure monitoring system and can give you additional information to help you in your clinical inputs. So in summary, multiple applications for the esophageal pressure monitoring system is possible. At the moment, it is still a research tool, probably needs more clinical research before we actually put it into practice on a regular basis. It does help in guiding ventilation in difficult patients of ARDS, assessing the work of breathing, measuring heart-lung hemodynamic interactions, and appropriately organize your cardiac output monitoring and cardiac output assessment, weaning of difficult patients as well. There are some technical and technological glitches which are still present in the current generation systems and probably need a better technology for that. But the most important thing, it's a minimally invasive device and may be a replacement for, may play a complementary role in our current clinical practice. Thank you.